Hello and welcome to the second of the past test video series in cardiology. In this video we're going to concentrate on electrophysiology and some physiology in the heart. We'll start with the question. Question 1. An elderly man develops syncope. He's known to have ischemic heart disease. Peripheral pulses are absent and an ECG reveals wide complex tachycardia. Immediate management consists of which of the following? Give you a few moments just to think through your answers. If you answered D, DC cardioversion, you're absolutely right. And clearly this is a scenario which one clinically would become very worried about. You've got a patient with an established history of ischemic heart disease, presenting with a broad complex tachycardia, and one would be very suspicious this was ventricular tachycardia. And then the examiner's go on to tell you that his blood pressure is low, his pulses are absent. So this is clearly something we need to act on very, very quickly, really independent of the cause. And what we need to try and do here is clearly re-establish sinus rhythm. You'll be aware of many ways of doing that, but in an emergency situation, by far and away the best way to do that is with a DC cardioversion, and that's what the examiners expect you to have here. In terms of other options on our list here, programmed stimulation. Well, this is a technique we use in the coronary catheter lab and in the electrophysiology lab to try and stimulate ventricular tachycardia when we're going to try and ablate the ventricular tachycardia. So to look for a particular pathway which we can go on to ablate. The question hints that this may well be the result of underlying ischemia, and it may well be, but we can't really give any treatment, whether it's primary PCI or thrombolysis, until the patient is stable, and we need to get him back into sinus rhythm. So B really is an irrelevance here. You'll be aware from your ALS protocols that one can administer drugs such as amiodarone or lidocaine, but be very, very cautious administering lidocaine, which is a myocardial suppressant, when someone presents with a very, very low blood pressure, because what you're likely to do is make things much, much worse. You'll suppress his myocardium, lower his blood pressure, he'll probably arrest. If he doesn't arrest, then if you do move on to DC cardiovert, you'll probably find that his blood pressure doesn't shoot up where you would expect it to, and it still stays very, very low, meaning he may develop pulmonary edema and the consequences of that. And then other treatments such as administration of phenylephrine and carotid sinus massage. Clearly in this scenario, that's not an ideal situation, and you really want to avoid doing that. So clearly the good evidence here is to go for DC cardioversion. Now, ventricular tachycardia is something which you should be very familiar with, and it's something which it comes up in the main course syllabus for MRCP Part 1. Here in this slide here, you can see a typical electrocardiogram of a patient in ventricular tachycardia. The leftward axis, broad QRS complex, all of which are wide and have a very, very similar morphology in each of the leads. You'll also see that in each individual lead, the baseline is very, very flat. And the reason for mentioning that is when we look at some other ventricular abnormal rhythms later on, you'll see that this differs markedly. Now, ventricular tachycardia, there is complete dissociation between the atria and the ventricle, both mechanically and electrically. So there's one pacemaker in the atrium, the sinoatrial node, which continues to fire at 60 beats a minute. And there's a pacemaker in the ventricle, which acts independent of the sinoatrial node. So you have two competing rhythm-generating systems. And as a result, you lose the synchronicity between the atrium and the ventricle. Now, if we look at the electrocardiogram, you can see some evidence of independent atrial contraction, and particularly focus your attention to lead V4, where you can see some little bleeps on the top of the complexes which correspond to the atrial electricity. Now, as a result of you losing the synchronicity between the atrium and the ventricle, we'll often see some abnormal features in our jugular venous pressure waveform. And these can include a fusion beat, and this occurs when the atrium contracts at the same time the ventricle is contracting. And you see a very big cannon A wave up in your jugular venous pressure. And occasionally you'll see a capture beat. Now, a capture beat is essentially something which we've witnessed lots of times in the acute setting, where someone has a run of ventricular tachycardia and then goes back to sinus rhythm. And you can see that on this diagram here on the far right-hand side. And essentially this happens when the ventricle is in a state of depolarization, and it's becoming progressively more repolarized, so ready to contract. And at the precise moment the atrium contracts, when the sinoatrial node fires, You have a normally conducted beat which travels down in an anterograde direction, and in many cases you have restoration of sinus rhythm. The other image you'll see on this slide is one of ectopy on the far left side. Of course, this is a frequently encountered feature on most electrocardiograms. We'll certainly see it frequently in electrocardiograms. And this, of course, occurs when there is another focus somewhere else in the ventricle, which is giving typically one beat infrequently of additional ventricular contraction. This per se is not ventricular tachycardia, but that focus, particularly if it's come from a scar as a result of an acute myocardial infarction and the fibrosis after that, may well be the focus for the preceding ventricular tachycardia, which can arise afterwards. I think we've covered most of the features on this slide here, so certainly you can get a Cannon wave in the JVP when the atrium is contracting at the same time as the ventricle. Because you lose synchronicity between the atrium and ventricular contractions, you can have variable degrees of filling. And again, because you've lost this electrical and mechanical connection, you see independent P-wave activity. Just want you to remember that the QRS complexes look very, very similar in each individual lead. They're regular and the baselines are flat, and that's vital for comparing a normal ventricular tachycardia to some of the polymorphic varieties, which we'll talk about later. Now move on to question 2. So question 2 is a 68-year-old man who's admitted with syncope. He's known to have ischemic cardiomyopathy. His medications include aspirin 75 milligrams, furosemide 80, lisinopril 10. An initial ECG shows sinus bradycardia with a rate of 50 and a right bundle branch block. He has various bloods taken, and he has a run of the following tachycardia. The question you're asked is, which of the following would be your initial line of treatment? If you opted for C, intravenous magnesium, you're correct. Many of you will be familiar with this electrocardiogram. It indeed is a form of ventricular tachycardia, but it's a different form. This is a polymorphic ventricular tachycardia, torsade de pointes. And you can clearly see there are marked differences between this when compared to the more standard ventricular tachycardia morphology we looked at immediately before this. Here you can see the baselines wander all over the place in each individual lead. It's irregular, and each complex varies hugely on a beat-by-beat basis. This ECG is also very interesting from another perspective, as you can see the likely morphology of the torsade de pointes. If you look in lead AVF, you can see a P wave followed by a QRS complex, and then you can see a very, very long QT interval. In that T wave is the next P wave and the next QRS complex. So you have a so-called R on T phenomena, which is then precipitating the ventricular tachycardia. In scenarios such as this, it's very important, the first step, to correct any electrolyte abnormalities. Okay? So although one may think DC cardioversion was a natural first step, frequently you'll find that this is fleeting. So you have runs of torsade back in sinus, runs of torsade back in sinus. So really the treatment's got to be aimed at correcting everything which is correctable first off. Okay? Amiodarone, I know it's a drug which we frequently will administer in many circumstances, and often is your friend in casualty when someone comes in very sick with an arrhythmia. Here, it doesn't work very well, and indeed may paradoxically be worse and actually drive the arrhythmia, so I'd avoid that. Metoprolol is a good drug at controlling the rate, and indeed is often used in very, very difficult to control subjects in combination with temporary pacing. So we pace them at a rate above the ventricular tachycardia, and then we administer the metoprolol. And slowly we can bring down the rate and aim to control the torsade rhythm and hopefully keep them in sinus rhythm and prevent them having these runs of ventricular tachycardia, which can of course be very, very troublesome and very symptomatic for the patient. So, as I've said in that slide there, we saw a beautiful illustration of how a long QT led on to the development of torsade de pointes. And this is certainly an important area which you should all be familiar with for your examination, certainly the causes of long QT. So let's go through some of the drug causes. So there's the Vaughan-Williams drugs, so classification drugs 1A, 1C and class 3, which can precipitate this. Then drugs, of course, all of which we frequently prescribe, so tricyclic antidepressants and phenothiazines, phenytoin, then antihistamines, chlorpheniramine, and a drug called tafenidine or Trilidan, which is actually withdrawn from the market because it was causing deaths as a result of prolongation of the QT interval and in young kids who then had episodes of torsade, and then this sadly deteriorated into VF and then they're arrested. So this drug was withdrawn from the market. And then other drugs which we prescribe routinely as antiemetics, such as IV Stemetil, and antibiotics, such as IV erythromycin. Okay, will happen with oral erythromycin, but there's a higher occurrence of a long QT interval with intravenous erythromycin, and certainly that's a question which comes up frequently. Now, these drugs can all be, their effect can be upregulated via modulation of the liver enzymes, and here we have to be familiar with ketoconazole and grapefruit juice, which can upregulate their effects and can predispose people to even longer QT elongation. This is, of course, particularly important in people who have ion channel defects in whom they already are markedly predisposed to elongation of the QT interval. Now, there are causes other than drug causes, and these will be congenital causes, so Javel-Lang-Nielsen syndrome and Romano-Ward syndrome. It's been linked to sudden infant death syndrome, so this is typically very young babies who are found dead in the cot. Unsure what the cause of this is, and certainly the genetic studies have shown that in some of these children there are ion channelopathies. As I said, patients who have electrolyte disturbance, so if you have a low calcium, low potassium, low magnesium, this can all predispose, as can abnormal metabolic states, so starvation or liquid protein diets, hypothermia, and then rhythm problems such as bradycardia. And people with bradycardia are more predisposed to developing an RNT phenomenon and then having episodes of torsade. There are some congenital abnormalities such as right ventricular dysplasia and hypertrophic obstructive cardiomyopathy. And then we have in some inflammatory and ischemic causes, so this may be a myocarditis or ischemic heart disease. And then two common associations will be mitral valve prolapse and hypertension. So clearly there are lots of things there which, both in terms of drugs and non-drug causes, which can predispose you to long QT syndrome, and certainly these can come up frequently in your examinations. It's something I'd try and get a really good grasp of. If you do, it kind of makes answering that question very, very simple. So move on to question 3. This is a 19-year-old patient with known Wolff-Parkinson-White, presents to the emergency department with a 2-hour history of rapid palpitations, so not an infrequent presentation. And again, a very frequent presentation when you actually come to see the patient. There may have been delays in A&E, for instance, and all the symptoms are settled. You review the electrocardiogram, which we'll see shortly, and then you're asked for your advice. How do you manage this patient next? If you answered A, ablation of the accessory pathway, you'd be correct. This slide on the screen you can now see shows the electrocardiogram from the patient we discussed in the previous question. I'd just like you to have a look at this for one moment to see if you can spot any of the abnormalities. Clearly you can see, as is here, just like when the patient was seen in casualty, he's now returned to sinus rhythm. But there are some subtle clues here which give away the abnormality. I'm now going to zoom in and look at V4 and V5 to identify these in more details. You can see there's a triad of features here. One, there's a short PR interval. You can see at the top of the slide. There's a delta wave, this so-called slurring of the QRS complex, and the whole QRS complex as a whole is broad. And these three features are pathognomonic of Wolff-Parkinson-White syndrome. Of course, a patient doesn't present with symptoms when they have this underlying ECG. They present with an atrioventricular reentry tachycardia or an atrioventricular nodal tachycardia as a result of having it, so it predisposes them to that. And we'll look at one of the accessory pathways now which can cause that. So on the slide here you have a schematic of the electrical pathways of the heart. The top left you see a red dot which is a sinoatrial node which normally conducts down the solid arrow to the atrioventricular node and then down through the AV junction, if that's a solid white horizontal line, into the bundles which go down into the ventricle. Now, in patients with Wolff-Parkinson-White, they're born with an abnormal accessory pathway, which you see is the dotted white line. Now, how this differs from the normal conducting pathway, so the normal way the sinoatrial node conducts to the AV node, is that it's much, much faster. So it's much more rapid. And as a result, conduction occurs down that preferentially over and above the normal route. So this will essentially mean as electrical activity comes down from the sinoatrial node, down the accessory pathway, down to the AV junction, which is the far right side of your screen there, this happens before the electrical activity travels down the normal route, and as a result, the PR interval appears much shorter. However, when the electrical activity hits the ventricle, it's now not in the nice neurological conducting tissue, it's not in the bundles. Now it's actually in muscle. And as it conducts through the muscle, it conducts much, much slower, and as a result, we have an upslowing of our QRS complex, the so-called delta wave. And it's not until that electrical activity gets into the bundle of His that you have restoration of a more normal appearing QRS complex and what looks like a more normal ECG morphology. So this is one typical Wolff-Parkinson-White pathway. Now, what happens when these patients develop arrhythmias is that rather than the electrical activity just originating from the sinoatrial node, activity comes back up retrogradely, as you can see here, up the bundle of His, through the AV node, and then auto-activates the accessory pathway. So you have a circuit which just goes round and round and round and round and round, and it continues to go very, very rapidly, round and round and round, giving the patients symptoms of a tachyarrhythmia. Of course, one can see when you look at a schematic diagram like this, it really is quite easy to treat if we're able to dissect through the accessory pathway. And thankfully now we can do that at ablation. And this technique involves us putting tubes into the veins of the leg, passing them all the way up to the heart, mapping out these pathways so we see where the accessory pathway runs, and then zapping through the accessory pathway with either electricity or cryoablation to destroy that. Once that's destroyed, all electrical activity will then go down the normal activation pathway, so from the sinoatrial node down the solid arrow to the AV node, and then normal conduction down the bundles. So the ECG will normalise and will remove the chance of this patient then developing tachyarrhythmias in the future. So clearly a huge step forward in the management of these arrhythmias over and above that which used to be drugs for many years. Of course, if you do see someone who comes in with for instance, a Wolff-Parkinson-White rhythm has an active re-entry pathway going on at that time, what you need to do is try and block the AV node. And what the most effective drug at doing that is adenosine. And you administer that via an IV bolus using into the antecubital fossa, and it blocks the AV node, terminates the rhythm, and hopefully restores sinus rhythm. When you do that, it's of course important and it's very useful for the electrophysiologist to have an electrocardiographic recording immediately before, during and after administration of the drug, as this enables him to have a good idea of where to go hunting when he's looking for the accessory pathway. And this can be used both in the termination of various arrhythmias, but it's also often diagnostically useful in differentiating between a supraventricular and a ventricular tachycardia. For instance, if someone has atrial flutter and we block the AV node, then all we see is the atrial activity. Whereas if they have a ventricular tachycardia and we block the AV node, it makes no difference to the morphology at all, because all the rhythm is arising from the ventricle itself. Questions frequently arise with regard to adenosine in terms of contraindications. So you should just familiarise yourself with these, and these are really the effects of increased efficacy, so heart block or sick sinus syndrome. So usually in patients who have disease conducting systems already. People who have asthma or COPD, it can make them more wheezy, so you need to warn people about that beforehand. And of course its effects can be upregulated or downregulated by dipyridamole upregulation or theophylline's downregulating. Now you should always, of course, warn patients before you administer this drug that they're going to have some side effects. And these are common and most people experience these. So this is going to be flushing, chest tightness, shortness of breath, nausea, and then a period of bradycardia, which often makes the doctor very nervous as it appears that the heart's stopped beating, but that usually only lasts a few seconds, and then to have restoration of normal sinus rhythm. So Wolff-Parkinson-White, reasonably common, 1.5 to 2 per thousand, slightly more common in men than women. Interestingly, most patients have got that abnormal ECG, so they've got the underlying triad of features, the narrow PR interval, the delta wave, and the broad QRS complex, but very few are symptomatic, so only 3 to 4% are symptomatic by the age of 60. Right. Probably not a problem, but it's something which often presents a kind of management type problem if this gets found for some other reason when they come in for other investigations, they've found to have an abnormal accessory pathway. What do you do about it? And usually the case is nothing, providing they don't have symptoms. It's associated with mitral valve prolapse and congenital abnormalities such as secundum ASDs, Epstein's anomaly, hypertrophic obstructive cardiomyopathy, and thyrotoxicosis. And as we discussed earlier, the real problems here are you can have atrioventricular entry tachycardias, you can go on to develop atrial fibrillation and atrial flutter. The gold standard treatment here, and I can't really overemphasize this, is ablation. We can offer ablation safely to the vast majority of patients, and it really negates the need for them then to continue to take tablets, which is great, especially as young people frequently present with this. If they're not keen on ablation, or maybe they're not suitable candidates, then Vaughan Williams classification drugs 1C, class 3, or class 2 can help. Avoid digoxin, however, as this can precipitate ventricular fibrillation. So there are two main types of Wolff-Parkinson-White. There's a type A, which is a dominant R wave in lead V1. So on the slide here, you see on the right-hand side, there's a very dominant R wave in lead V1, and not a lead we typically look at on the electrocardiogram, and that's compared to what the R wave normally looks like. So that's the waveform just on the left, so the normal waveform. And when the R wave is very big like this, it's a left-sided pathway. Other causes of a dominant R wave in V1. This is a topic which the examiners frequently talk about because it's something which you're expected to know, and it can often, of course, be diagnostically useful if you're in A&E, you see an ECG which has got big R waves, and you wonder what the differentials are. Having a list in your head can often be useful, and that's certainly what they think, and certainly questions arise from this. So if you see a big R wave in V1, it could result from a true posterior myocardial infarction. They may well have, these are all right-sided things, so right bundle branch block, Wolff-Parkinson-White type A, or dextrocardia, or right ventricular hypertrophy, so lots of right-sided things, or they may have an underlying muscle problem such as Duchenne's muscular dystrophy. So now move on to question 4. 54-year-old man referred with increased swelling of his ankles and abdomen and a degree of shortness of breath on exertion. His jugular venous pressure is elevated with a prominent X and Y descent. Apex beats normal. ECG shows atrial fibrillation with widespread non-specific ST segment abnormalities, and his echocardiogram reveals preserved left ventricular systolic function with biatrial enlargement and an estimated pulmonary artery systolic pressure of around 60 millimeters of mercury. Chest radiograph shows atrial enlargement but no other abnormalities. So what's the most likely cardiac diagnosis here? If you said restrictive cardiomyopathy, you're right. Restrictive cardiomyopathy will often have a pathognomonic prominent Y descent and frequently also associated with an X descent. This can be both fibrotic in nature, or it could be a part of an infiltrative process such as amyloid or sarcoid or hemochromatosis. It usually results in the ventricular relaxation being impaired, and as a result, people may present with symptoms of reasonable systolic function, bad heart failure, but have impaired relaxation, which means that they have evidence of so-called diastolic heart failure, which means they're very, very symptomatic and present with breathlessness and edema. So we've briefly mentioned the X and Y descent in that question. I'm just going to move on to just have a look at the physiological background behind that. On the slide here, you can see an electrocardiogram at the top in blue, and underneath that you can see the jugular venous pressure waveform. Now, a jugular venous pressure waveform is a very simple concept, really. So essentially, it's a column of blood which you see up in the neck, which rises and falls as the right atrium fills and empties of blood. So throughout the cardiac cycle, of course, the right atrium is either contracting or filling or emptying, and that results in the various squiggles we see in the jugular venous pressure waveform. So let's go through that. The first wave we see is an A wave, and this occurs when the atrium is contracting. As it contracts, it squeezes blood through the tricuspid valve into the ventricle, But as there's no valve going back into the internal jugular vein, blood also gets displaced upwards as well. So that gives you that peak. The X-descent occurs, and that's the next big feature we see on this waveform, as the atrium relaxes. As the atrium relaxes, all that blood which had been displaced into the internal jugular vein is now allowed to fall back into the atrium, and as a result, the waveform falls very, very dramatically. You'll then see it appears to plateau off, and then it starts to slowly increase again. And this gives you, this peaks with the V wave. And this is the result of passive filling of blood coming back from the head and neck vessels and the feet, filling the right atrium passively. The last prominent feature you can see there's the Y descent. And this occurs at the end of ventricular systole when the tricuspid valve opens and blood is able to move passively from the right atrium into the ventricle. Some of you may also have noticed a C wave, and that occurs in the middle of the X descent. This occurs when the right ventricle is contracting, and when the right ventricle contracts, of course the tricuspid valve is closed, but the tricuspid valve is a very weak structure, and when the right ventricle contracts, it causes the tricuspid valve to bow up very, very slightly, decreasing the volume in the right atrium, and as a result, a very small amount of blood is displaced upwards, and we see that as a slight deviation in the X descent of the jugular venous pressure waveform. Now, in reality, you're not going to see that unless the patient's attached to a monitor. And if they are attached to a monitor, you may well see that small blip, but its clinical relevance is probably very minimal, and you'll find that not many questions come up on this area. So let's look at some jugular venous pressure waveforms in various conditions. So first off, we have a look at atrial fibrillation. And the most striking thing you can see here is there's no A wave. There's no X descent. And the reason there's no A wave or X descent is because the atrium's not contracting. And of course, this is a feature which is a prerequisite of atrial fibrillation because the atrium is not contracting and it's just fibrillating away. Of course, we're frequently as clinicians presented with the problems which arise from this as a result of the atrium not contracting properly and the necessity to anticoagulate to prevent thrombus formation. But you can see that as the atrium doesn't contract, there's no X descent, but of course, there's still passive filling of the right atrium through the whole of ventricular systole, and you still have a prominent Y descent as the ventricle relaxes and the tricuspid valve opens and blood moves from the right atrium into the ventricle. So next we'll look at the scenario of tricuspid regurgitation. So the most striking feature you can see here, and I've highlighted this in blue, in the bottom left-hand image here, is of a big V wave. And this V wave occurs as the ventricle is contracting, rather than the V wave just being accounted for by blood returning passively into the right atrium. You also have blood being squeezed backwards from the right ventricle into the right atrium through an incompetent tricuspid valve. And as a result, you see this huge peaky V wave, and you have a much bigger Y descent. So that's the tricuspid valve being incompetent. What happens if you have raised arterial pressures here? So this could be as a result of pulmonary atresia, pulmonary stenosis. Well, here you can see the atrium tries to contract against a much higher pressure than it likes dealing with. And rather than squeezing blood forward, because the atrium is a low pressure structure usually used to dealing with pressure of about 5 millimeters of mercury, it finds it easier to displace the blood backwards, and that's indeed what happens. So you see we have a very, very big A wave here, far exceeding the A wave which you'd expect in a normal scenario. So this is much analogous to electricity, whereby fluid, electricity, will always try and move to the path of least resistance. If the atrium contracts and it can't push blood forwards, there's no valve to stop it going backwards, so the blood just will all move backwards. And of course, in contexts such as raised atrial pressure and in tricuspid regurgitation, as you see the last two illustrations, if enough blood moves backwards, this may cause dependent edema, hepatomegaly, a pulsatile liver, and so on, the other features we can associate with these conditions. And the last two waveforms I'm going to talk about are those of constriction and tamponade. So constriction and tamponade are both associated with an elevated jugular venous pressure waveform throughout the entirety of the waveform. Okay, so you can see they're both higher in all of the features. But you'll see with constriction there's a very prominent X and Y descent, but with tamponade there's just a prominent X descent. So this is a question which frequently comes up, and they try and trick you in this kind of questions by asking you which has an X and Y descent and which has just an X descent alone. So just remember that constriction has a prominent X and Y descent, and tamponade has just a prominent X descent. So now we move on to question 5. So you examine a patient in the emergency department. As part of your cardiovascular examination, you note the presence of reverse splitting of the second heart sound. In the absence of any additional clinical information, which conditions are associated with reverse splitting of the second heart sound? If you answer D, aortic stenosis, you'll be right. Heart sounds are often an area which unnecessarily confuse people and are really quite simple. We're just going to spend one moment having a look at the basic physiology behind them and explain some scenarios which can result in heart sounds becoming abnormal. By abnormal, I mean becoming very wide or reversed. So first of all, let's consider a normal situation. In this illustration here, you see there's a line with various blue and orange bars going through the line. The first one you see is the first heart sound, and the second 2 bars you see are the second heart sounds. The first line is the aortic valve closing, and the second line in orange is the pulmonary valve closing. You'll see that the gap or the interval between the aortic valve closing and the pulmonary valve closing narrows with respiration. So during inspiration, it's slightly wider than it is during expiration. When people refer to wide splitting, all they're really referring to is a widening of the time interval between the aortic valve closing and the pulmonary valve closing. It's a very, very simple concept. You'll see that the diagram looks much the same as it does in the normal case, but the interval, the gap, is slightly wider between the two. And this is both for inspiration and expiration. So let's consider what can cause this interval to become wider. So it could be that the aortic valve is closing earlier. So it just means that it closes earlier, the pulmonary valve timing could be the same, but the interval gets wider. Or it could be that the pulmonary valve is closing later. So what scenarios can cause that? Well, certainly the aortic valve can close earlier if the blood is not going through the aortic valve, but it's being displaced somewhere else. So it's going backwards into the mitral valve, or it's going through a hole in the septum, so it's going through a VSD. So imagine all that blood gets effectively ejected out of the heart earlier, means that the left ventricle's finished contracting earlier, and the aortic valve will close sooner. On the other side of the coin, the pulmonary valve closure could be delayed, and that could be delayed due to a conduction abnormality, such as a right bundle branch block, a physical obstruction, such as pulmonary stenosis, or again, due to there being more volume there in the heart as a result of an atrial septal defect. The third thing we're going to consider is reverse splitting. And you'll immediately notice here that in the bottom panel, that the colours for the second heart sounds have switched around. So first of the colours you now see is a pulmonary coloured orange, followed by the aortic heart sound, both for inspiration and expiration. So now we have the pulmonary valve closing before the aortic valve. So what could have caused that? What could have caused that to occur physiologically? Well, it could be that the aortic valve is closing late, so something's causing the aortic valve to just be delayed. Or it could be that the pulmonary valve now is closing much, much earlier. So what could cause the aortic valve to close late? So it could be a physical obstruction, so it could be a stenotic aortic valve, or it could be a muscular outflow tract obstruction, such from hypertrophic obstructive cardiomyopathy. Could be a conduction problem, so it could be a left bundle branch block, which is causing delayed activation of the left side of the heart, or it could be due to right ventricular pacing. So all of those things will cause delayed contraction of the left ventricle and effectively delay the closure of the aortic valve. What about the pulmonary valve closing earlier? Well, much like in the last example, so widening of the heart sounds, where we see that when you have severe mitral regurgitation or VSD, that means that blood doesn't have to move out through the aortic valve and can go out via another route. If someone has a severe tricuspid regurgitation, That means that the blood doesn't all have to move through the pulmonary artery to escape into the lungs, but blood can move backwards through the tricuspid valve into the right atrium. And as a result, the right ventricle will finish ejecting earlier and the pulmonary valve can close sooner. This is also seen with a patent ductal arteriosus and a Wolff-Parkinson type B pathway. The other feature to also bear in mind, which comes up in your MRCP examination, is what you expect to see or hear in a subject with an ASD. This is, you get fixed splitting of the heart sounds, whether it's in inspiration or expiration. And the explanation for this is you don't have any variation in volumetric status between the right and left side of the heart, which you normally get as a result of greater or lesser degree of filling of the lungs with the respiratory cycle. So ASD, you expect fixed splitting of the second heart sound. Now we move on to question 6. Normal pregnancy is associated with which one of the following hemodynamic changes? If you answered B, a 10 millimetre drop in diastolic pressure during the second trimester, you'd be right. The reason for this is it's really a bit like exercise. When you start exercising, you peripherally vasodilate, your total peripheral resistance falls, and as a result, your heart has to compensate by beating harder and your pulse pressure gets slightly wider. In pregnancy, as the pregnancy progresses, you have more and more vascular beds to perfuse, and certainly the resistance becomes less, and as a result, your diastolic pressure falls. I'm sure you'd agree that most of the other features here are incorrect. So blood volume increases markedly during pregnancy. Often you'll find there's a tachycardia, a soft aortic flow murmur, and hopefully you wouldn't expect to have pulses alternus, which would be a very, very worrying sign that something was going wrong from a cardiovascular perspective. So we've spoken about the first heart sound briefly and the second heart sounds. What about the third and fourth heart sounds? They come up, and certainly you should be aware of these. So the third heart sound is a passive phenomenon, and this is filling of the right and left ventricle at the end of systole when the tricuspid and mitral valves open up. And of course, this is a normal way that in healthy young hearts we get most of the blood into our ventricles. I spoke briefly about that restrictive cardiomyopathy, which people get often as a result of having pronounced hypertension for many years, and indeed is a problem just of the elderly alone. And when you get that, the ventricle is stiff and it relaxes very, very poorly. And as a result, blood doesn't flow into the ventricle as quickly and nicely as it should do. When you lose that ability to fill, that predisposes people to heart failure. And that may well be a reason why people present, even in the apparent context of good systolic function or apparent good systolic function, with signs of pulmonary edema or a decompensated heart failure and peripheral edema. Of course, the third heart sound may be abnormal in conditions where the right atrium is becoming charged with more blood than it would otherwise would be. And such conditions include mitral regurgitation, where blood's moving back from the ventricle into the atrium, and in aortic regurgitation, where blood is moving from the aorta back to the left ventricle, and as a result, some of it will get back through the mitral valve into the left atrium as well. So at the end of systole, when the mitral valve opens, just more blood flows through into the ventricle, and as a result, you have a louder third heart sound. The fourth heart sound is again a normal phenomenon, but in young healthy hearts is certainly something which can be normal as a result of the atrium contracting. So when the atrium contracts, it gives an added kick, added impetus to squeezing blood from the right and left atriums into the left ventricle to aid filling. As I said, that can be normal in young healthy hearts. But clearly would be suspicious if we hear this in a more elderly heart, and certainly if we hear it as very, very loud, then we're suspicious that there may well be degrees of fibrosis as a result of a previous myocardial infarction, or the ventricle may become very calcified and fibrotic as a result of prolonged periods of hypertension, aortic stenosis, or hypertrophic obstructive cardiomyopathy. Now, differential diagnosis you should know for these, for the third heart sound, would be an opening snap with mitral stenosis or a myxomatous polyp, and for a fourth heart sound would be a split S1 or an ejection click. So that concludes the second of the past test cardiology videos. In the third and final video, we're going to look at myocardial function and some considerations around that which are vital for your MRCP1 examination.